And now I'm pleased to introduce our next presenter, David Vlahov. He will talk on the issues for communities in times of conflict. Dr. Vlahov is Associate Dean for Research and Professor at the Yale School of Nursing and Professor of Epidemiology at the Yale School of Public Health. His primary area of focus has been on urban health, which is some very unusual for Ukraine. His studies in Baltimore, Harlem, and the Bronx, which have served as a platform for subsequent individual, community level, and policy level intervention studies. He has led community-based participatory research to address social determinants in health. This work has contributed to new knowledge and to promote the health equity. And before you start, David, I just recently learned some articles, exactly not articles, but report from the National Task Force on Children Exposed to Violence in the US, which reported that up to 60% of children population in the big cities in the US experience some part of violence, abuse, or crime. And for example, if we will put it in Ukraine, it will be like a huge massive because it was never evaluated. It would be great if you say something regarding that and address this to the audience.
Very good. Good morning. And I want to thank Jerry Stimson and the organizers of the conference for inviting me to be here today, and to the Director General for chairing this session and asking a question that I think I should clarify. When we talk about violence, whether it's for children or adults, the measurement is not just physical violence, right? It can be emotional violence as well. So physical, emotional, psychological, we have to take all of that into consideration when we're doing that. And we want to be able to have prevention measures. We know from children that if they experience violence when they're very young, we call that adverse childhood experience, that leads to problems later on in life. So the prevention efforts are very important. There's more I can talk about that, but I have some material I'd like to share. A lot of the conference, well, let me say something about the intimate partner violence. And that is, we see that in the United States, and a lot of the attention originally was on the victims of violence. And how do you separate them out of the household, and can you create some services for them, right? Refuge. And that's important to have, but it's only taking care of the victims. And so there was attention to training the doctors and nurses on how to be more sensitive and appropriate with women that experienced violence. And so that training helped. But what we found is that we really need to be able to have prevention in the community. And so there was a lot of outreach to people into the community. And what we called it was bystander interventions. If you see something, say something, and then do something. And the idea behind that was to see if we could change the culture where intimate partner violence became unacceptable. And that is an intervention that started out in the community. But what we learned after that was how important it would be to take men who were sensitive to the issue of intimate partner violence to be the role models in terms of talking to other men, to say that this was no longer acceptable. And can we change the community overall? So we work with the victims, we work with the healthcare providers, we work with the community overall, and then we work with what we call the perpetrators, or the potential ones. So that's a little bit about what we do there. Now today, what I'm going to be talking about is harm reduction in conflict zones. And so I'm going to talk about events that we had in New York City with the World Trade Center when it collapsed in 2001, once the planes blew in. I was there, and we did studies, and we had to do things in the population. The second is going to be some work that my team did in Kabul, Afghanistan. And so obviously it's a security issue in a conflict zone. So how is it that we do risk reduction, harm reduction? And for the first examples, I start here with HIV, but it is not just HIV. I say HIV because so many people here have worked with HIV prevention. But as you see, a lot of this has to do with mental health. Post-traumatic stress disorder, depression, right? So there's big mental health consequences that happen over time. So the first that I'm talking about is September 11th, 2001. And I was in New York City when the airplanes hit the towers and the towers collapsed. And part of what I did as an epidemiologist was to have a team that would go out and do a random sample of New York residents, right? People that lived in the city, as well as people that lived in the metropolitan area. And we did a study to begin with, right, cross-section, and then we followed the same people for 2 years because we wanted to know not just what happened then, but what happened later. And the way we did that was to use telephones, right, to do random digit dial, it's called. And we started in the first 2 months after the events. And the reason why is PTSD, right, post-traumatic stress disorder, happens at least 1 month afterwards. Before that, it's called acute stress syndrome, and almost all of us were acutely stressed. But what happens for the people that persist? And what we found is that there were elevated rates of post-traumatic stress disorder, and there was also elevated rates of major depression, right? Very important. And what we found is that all the earlier studies in disasters had looked at the victims. They had looked at the first responders. They had looked at their families. And the question we had was whether other people in the population outside would be affected as well. And so that's why our sample was all New York City residents. And what we found is that among the people that were affected directly, that the rates went up tremendously. But even for people that were not directly affected by the disaster, we saw an increase in PTSD. And the interesting thing is that 25% of the people were affected and had very high rates, and then we had 75% that had a somewhat lower rate, right? So lower rate, more people. And so when you do the actual count of people that had PTSD, it was equal in terms of the true numbers, not the rates, but the true numbers. And what that told us is that if you're going to have a response to mental health needs in a population, that you need to consider everybody, not just the victims, everybody that's affected, all right? The other thing that we saw besides PTSD and major depression was an increase in cigarettes, alcohol, and marijuana. I can tell you very soon afterwards I was drinking a little bit more because I was very upset, and I think that's true for almost everybody. But then what we did, remember I said we were following everybody for out to 2 years, every 6 months. And what we saw is that for 2/3 of the people, they spontaneously recovered, right? PTSD went away just on its own without treatment. There was a smaller proportion that had what we called persistent PTSD. And the risk factors for persistent PTSD were having a panic attack during the initial period, that predicted who would have it later on. Yeah? Women were a little bit more likely to have it. Older people were much less likely to have PTSD, and I think that's based on prior experiences. So most people recovered. There were some that were persistent, and then there are a few that had a delayed onset of PTSD. Very, very small numbers that you wouldn't see PTSD until 1 year later. So now what we see also is with alcohol, marijuana, everything went down to baseline, right? It had gone up early and people stopped using the way they were before. But cigarettes, if somebody started smoking after the disaster, that continued, right? We know this because tobacco is so addictive, right? Tobacco is 32 times more addictive than opiates. So at the same time, we did a street survey of drug users that were in Manhattan, the island that is the center of New York. And we've been doing outreach to drug users for a long time. And what we thought is that with bridges and tunnels closed for security, that people would start going into withdrawal, right? And that we would have a lot of problems that drug users would have afterwards. But we found there was no change in drug use, even though bridges and tunnels were closed. And what that told us was that the drug users had supplies nearby, right? I guess just in case something ever happened like that. So it's an interesting observation. Now my attention here turns from New York City to Kabul, Afghanistan. And I want to thank my team, particularly Catherine Todd, who was the person on the ground. And when we look at Afghanistan, there are different factors that were happening at the time. The opium trade, insurgency, and HIV/AIDS, which was our concern. And the relationship between those has regional consequences. So you'll see on the left side of the slide that we're talking about the factors of insurgency, so there's violence and security becomes deteriorated. But that also means less control over opium trade, so there's drugs that become more available. And then people from the countryside moving into the cities for more security, and again we see overcrowding. So there's drug use that's happening, there's more supply of drug. And so the question is, does that increase risk behaviors? Does it increase HIV and hepatitis C in drug users? And is there less likely for people to have and to go to harm reduction services? And so our concern was there should be a call for harm reduction programs. So what I'm going to show you in this slide is cross-sectional survey, right? One time going out, finding people through outreach and originally through some of the community centers, drop-in centers, and then out into the community. And so on the column on the left is the years, right? It was 2 series of surveys. The second column is the number of people that were surveyed. It's about the same. The third column is the rate of HIV infection, prevalent infection. And you can see that it's 3% in 2005-06 and 2.1% in 2009. Hepatitis C, much higher, right? 36 and 40% the same. And that's some rates that for both of these are lower than some of the rates that we've seen for cities in the West. The proportion that ever shared needles whatsoever was 50 to 70%, so it went up over time forever. But you look at harm reduction, were people using it? 2005 and 6, it was 1 person, yeah? So that's why that rate looked so low. In 2009, it was more than half. So these are the rates, and what we see is that data from Kabul around the same time in Pakistan, the prevalence of HIV was 51%. So definitely a need to have effective outreach programs. So I finished the cross-section, and now I'm talking about the next study in 2007, which was 2-year follow-up study. And so what we had was 385 people. They were all male. They'd been injecting on average for 2 years, and they had 1 or more follow-up visits. And so what we see is the HIV incidence, 1.5 per 100 person years, hepatitis C, 35.6, so it's still a tremendous amount of transmission. And we had information on deaths, and deaths, 9% of the people in follow-up. And most of those deaths were related to overdose. And it was only at the end in 2009 that Narcan was being distributed at that point, not earlier. Now look at what happens with harm reduction services. At baseline of this follow-up study, it was 60 to 70%, and 18 to 24 months into the second year, it's 50% overall, so a slight decrease that we're seeing. And again, it's looking at an environment that is a bit risky. These were at drop-in centers, originally the old Russian Cultural Center in West Kabul, and then eventually, because of police and neighbors being upset about what was happening, there were 4 centers that were set up elsewhere. There was drug treatment available through some of these centers, but again, not enough places for the number of people that would need it, right? So the frequency of changing from injection to smoking was seen in people. Before they went into drug treatment, while they were waiting, it would be told to stop injecting and smoke instead. And what they found was that the rate of hepatitis C, new infections, went down tremendously. So if you can't get a person to stop drug use, get them at least to stop injecting drugs. One of the things that people had questions about is, what about insurgent attacks, right? And how is it that that affects people? And what we found is that the peak period, right, we did counts over time of what was happening, that was not related to hepatitis C or HIV new infections. So the harm reduction in the zone of insurgency 2006 through 2009. In 2006, we see the insurgent attacks was 95 episodes. In 2009, if you go across to the right, it's 175. So an increase in the number of events. But also in that period, you look at harm reduction programs, there were 3 in 2006 and increased to 5 programs, and it continued to increase after that. So what were the risk behaviors during the peak periods of conflict? And we compared conflict periods versus low insurgencies. And what we found was that needle sharing was at its greatest at that point, 8 times more likely to be sharing needles during that period. You know, you don't want to go out and get exposed to violence from other places. And so the idea there was that syringe sharing increased during these peak periods, and therefore you want to be able to have instruction for coping with conflict and prepare clients for harm reduction, their needs during periods of conflict. What is it that you're going to do? How is it that you're going to prepare yourself in that situation? Now, I should say that during this period, there were no sites that were harm reduction sites that were bombed, or attacked directly, but it was happening in communities all around them. So services that were added 2007, 2009, more drop-in centers, motivational interviewing, medical care, HIV testing, drug treatment, shelters, meals, and like I said before, 2009 added naloxone. So the perceptions, what is it that we did for interventions in the community? The idea was to bring all the stakeholders together, government officials, civil society, people from the community, available people that are from the community. So there was a presentation, some of these results, panel discussion of the different people, speeches from the Ministry of Health to show that the government was supportive of harm reduction, member of parliament, and then the local media covering the event so that the information could be disseminated more widely. It's a little bit like the violence that we were talking about in the beginning of intimate partner violence. You have to think about how you get a whole community to get behind the issues of harm reduction. So again, in conclusion, we want to increase the availability of drug treatment and provide training to people to have them become more socially integrated. And again, the harm reduction that everybody here is familiar with, condoms, syringe, counseling, HIV testing, they need to be increased over time. Thank you very much.
Thank you, David.